Hello, my name is Joseph. I'm at Primary Care Health Sciences at Oxford, working on the Professor Stavros Petrou, and our work stream is 3.2 on health economic evaluation. But today I'll be talking about mainly around how we are and we will use ELAROS data to kind of derive health economic data essentially for calculating parameters. But for a bit of a context, original plan in the protocol of locomotion was to conduct cost effectiveness of the differentiated non-COVID care strategies across 10 clinics. But I think it's unlikely that we'll have sufficient differentiation in care strategies to go ahead with our original plan.
20 and 30%.
Really? Yeah.
See, that's how good we are, Manoj.
Moving on. Okay, so I think the recruitment rates so far is looking really good. So let's keep encouraging people because obviously it means we can do more with the data. I think the call to bring in some people from social media. It looks all right so far. Fingers crossed. Darren might tell me not later on when we look at the data properly, but adherence is looking good generally. The red cap data as well. So we've got really fantastic engagement. So thank you for you advised us really well at the beginning. We spent a lot of time going around in circles about this. Okay, we've got 12 more weeks, haven't we? Data selection. Yeah. So yeah, thank you very much to the next team and to Faye and Ashwara at the back, and they've been doing all the work on this.
Hello, my name is Joseph. I'm at Primary Care Health Sciences at Oxford, working on the Professor Stavros Petrou, and our work stream is 3.2 on health economic evaluation. But today I'll be talking about mainly around how we are and we will use ELAROS data to kind of derive health economic data essentially for calculating parameters. But for a bit of a context, original plan in the protocol of locomotion was to conduct cost effectiveness of the differentiated non-COVID care strategies across 10 clinics. But I think it's unlikely that we'll have sufficient differentiation in care strategies to go ahead with our original plan. I think currently the plan is to do some kind of a modeling study around focusing on the POT screening and kind of hypothetical intervention for those screens to be to have POTs. So I guess I'm working with the Imperial team, and hopefully when the ORCID data comes in, we'll try to plan around what to do with that. But I guess the current main strategy is to look at locomotion as the biggest observational study of long COVID patients so far, and to derive as many observational data we can on the impact of long COVID on various health and health economic variables of long COVID patients. So the real main point that I just want to put out here today, and it's probably the only point, that we need a high response rate for the Health Economics Questionnaire. I've got some anecdotes saying it's the most complicated one at LRRs, and I don't like it. Response rate currently is sitting around 600 people who respond to the Health Economics Questionnaire. EQ5, you've got about 1,300. In C19-YRS, we got about 1,100. But in this age of big data, we really like pushing up to 4 figures. So if all those in contact with patients, if you can really try to ensure that you get at least one response on the Health Economics Questionnaire while they're enrolled, and as a bonus, maybe another one for the follow-up. So just two points. And hopefully for the rest of this talk, I'll hopefully be able to convince you why it's important.
So I ask a quick question, and just because I didn't want to lose that slide. First point you said is unclear. We have sufficient differentiation in the care strategies. Is that not contradictory to what actually Trish found in in the QIC, that every clinic is different, they've got different histories, the way they do things are different. You can't standardize care. But we are saying here, unclear whether we have sufficient differentiation. So which one is true?
Probably which is true. Something I dropped down on train.
So my question is, the work can still be done. You shouldn't be given up. You shouldn't give up, I think, because they're all different, and they're all collecting the same outcome.
I think though maybe what he's saying is that by the very nature that we're involved with the locomotion studies, we are probably quite engaged as teams, all of us, and actually the clinics or the teams that we need to look at this in are the ones who are not so engaged in research, or we don't have a key person, or it's just in their job plan and that's why they're doing it. Those people, why spend the extra money on us compared to that?
That's another reason why you should fill out the Health Economics Questionnaire. Because the first part of the questionnaire, we actually ask you what services are being received at the specialist clinic. And it's actually the only information platform or space where you can actually fill those out. So the only way you can understand what is actually going on across regions if you fill out the Health Economics Questionnaire.
Can I just, because I've been involved in your work package as well, I get where your question's coming from, Manoj, but there are so many variables of how the clinics operate differently that's what I think would make it difficult to analyse. It would be so complicated. Whereas if there was a sort of, you do this pathway or you do that pathway, comparison would probably be easier. But I think there's too many variables and differences, aren't there, in how to solve it? Is that right, Trish? You can sum up, thank you. So I agree with both.
Yeah. Right. So I think I'll just go quickly over what information is being collected by the Health Economics Questionnaire. So as I say, the services being received at the specialist clinics, and then basically everything that you can attach pound sign to. Right. This is the money. This is the economic consequences of long COVID. It's very important that we get an accurate picture. So every time a patient records a GP contact due to long COVID symptoms, we cost that in as £60, and that's the economic impact on the NHS. And if you want to make a case for increased funding in long COVID, we need as accurate as comprehensive information of all the aspects, everything from private care expenditure, their taxi rides to hospitals, whether their husband have to give up their job. We have to really get as comprehensive information as possible, and that all gets translated into a monetary amount. And there are two versions, the baseline one and a follow-up one. And I said one response for each would be really ideal to understand longitudinal trajectory in all these outcomes with money signs attached to. Another real strength of ELAROS is that this can be combined with patient-reported outcome measures, which I think the big surveys like ONS don't actually have. I'm sure they have capacity to do another survey like this, but this is a real unique strength of ELAROS. So we can combine the economic outcomes with the various patient-reported outcomes. So we have EQ5D. EQ5D is basically the main health outcome measure that health economists will use, NICE will use to approve funding decisions. So it's a very unique strength of ELAROS that they have this. We also have a C19-YRS, the first validated disease-specific measure. So again, very crucial that we complement this with a robust health economic outcomes, so we understand what is driving the various economic outcomes. And yes, there are also other things that are not captured in routine care data, like GP record basis. So I think I might be corrected, but I don't think they have things like number of when the infection occurred that led to long COVID symptoms. We don't quite have information on occupation industry, and there's a space in the ELAROS Health Economics Questionnaire and also C19-YRS that people can put free text response on what's really causing them employment problems, what's really causing them activity limitations. So these are really important information that can only go through ELAROS. I think ELAROS should give me a part-time contract. Anyway, and I'll just present now the results of the preliminary analysis. So this analysis of the baseline Health Economics Questionnaire of the people who enrolled for a 6-month period from August to February. And response rate is 50%, so we have a sample size of about 366. As I said, we really want to push this up to about 1,200. We're now sitting at about 700, so for the next 6 months, we can try and push it up to 4 figures. I think 360, we kind of just about reached the limit of what can be published, but really we want something in the 4 figures. So this was the change in their work status. So 23.5% reduced their paid work hours, about 17% no longer engage in work due to long COVID symptoms, and they also had no work income stream from their long-term sickness leave or other streams. About 12% no longer engage in work, but they're receiving some kind of a compensation during that time. And then so over 50%, as Claire mentioned, have had either reduced work hours or they quit employment altogether. So put this in comparison with other populations. This comparison with the general population in the UK, according to Department of Work and Pensions. So you see on the second column here is the rate in the general population of either unemployed or economically inactive, and the third column is in our sample, and you see the ratio. So there's a ratio of 4.1 between in the economic inactivity rate for men who are aged 35 to 49. It's a massive increase in unemployment and activity rates. We can compare that with other diseases. So the employment rate, not unemployment, employment rate in our sample was 53.5. That compares to about 60% among multiple sclerosis patients, about 50.9% among breast cancer patients. We put the number on the productivity loss, and we estimate it to be about £3.3 billion per year. If you extrapolate from our sample to everyone in the UK who's reporting a lot of activity limitation due to the long COVID symptoms. Compare this to chronic fatigue syndrome. One publication put it at £144 million per year. So long COVID is having a massive impact compared to chronic fatigue syndrome. And actually, I had a look. It's just this morning. Early breast cancer, their annual cost to the productivity loss is about 140 million as well. So long COVID is having a massive impact on productivity in the UK, and this is why you need to fill out the questionnaires. This is just the productivity loss. This is not incorporating things like impact on the NHS, impact on social care, impact on people's private care expenditures, impact on people, informal caregivers, personal finances. You put that all together, we can make a really strong case, economic case for long COVID care. So this was how, for people who remain in employment, how has their long COVID symptoms affected their work performance? So you see a massive increase in the work performance rate. 0 is little and 100 is profoundly. However long they've had long COVID for, you see a massive increase. This is the impact on people's monthly work income. So for people who've had long COVID for more than 2 years, we see that they experience about 42% drop in their monthly work income. And this actually information can only got from ELAROS. The ONS survey, I think Davis et al. That was cited by Rory, didn't collect income information. They're putting employment. So another strength of ELAROS essentially. And we also account for informal care receipts, and we put the numbers together. So I mentioned 3.3 annual cost. This is the aggregate cost. So this is from each person's start of their infection to the date of their survey. What's the aggregate loss due to their loss in work hours or loss in employment? And we're putting in about 5.7 billion in terms of productivity loss and about 4.8 billion due to informal care receipt. So this is assuming that if informal carers are not providing receipt, it would not be replaced by social care or private care, etc. So it's called replacement cost method. So overall cost, extrapolating, we can put it about over 10 billion. Actually, if you read the paper, I actually got numbers the wrong way around. So if you remember, I put it about 4.1 billion, but I noticed on the train up here that actually mistakenly swapped the numbers around. Yeah, sorry. So when the reviews come back, I'll change the number.
When Stavros is online, ask him why he didn't do it.
Yeah. Vicky actually spotted an error in the calculation. Anyway, so at least we can say we weren't overestimating. And we also did some multivariate analysis, found some good stuff like EQ5D being associated with a person's ability to return to the same work hours as pre-COVID, but also found C19-YRS also had an independent contribution to that, on top of EQ5D. So yes, so as I mentioned, it's not just the productivity and the informal caregiver receipt care burden that has an economic impact. A big aspect is NHS, impact on NHS. So that's the next work package. That's why it's so crucial that we have a high response rate on this. So we get an accurate costing. And we'll double check that with the ORCID data to make sure this LOCOMOTION self-response kind of is validated with kind of routinely collected data as well. And another paper that I will try to write is the understanding longitudinal trajectories between EQ5D, C19-YRS, and all these kind of health economic impacts. Yes, and hopefully we'll get all this done in the next 6 months. Okay, thank you.